Our final talk is going to be Dr. Lawrence. Dr. Lawrence, please join us.
Thank you, Dr. Dawson, for the invitation. These are my disclosures. There were two schools of medicine in ancient Greece, Hippocrates and Asclepius. Hippocrates, the mainstream opinion, tended to focus on the diseased organ and develop scientific, rationalized treatments for it. However, he somewhat neglected the individual. Asclepius, on the other hand, who happened to be the son of the god Apollo and a mortal woman, was more interested in the individual's response to that disease process. This is clearly demonstrated in this relief. You can see Hippocrates is examining the patient and looking at the diseased organ, whereas Asclepius is looking into the patient's eyes. You can also notice here that Asclepius is holding a snake. You can always recognize him by that, and that's because a snake was the primary modality that he used. He was not a radiation oncologist, or not yet at least. Now, if we jump 2.5 millennia into the present time, pancreatic cancer is a problem and it has an increasing prevalence. The vast majority of these patients, unfortunately, suffer from severe and very characteristic upper abdominal lower back pain that tends to worsen over time and responds poorly to treatment. That abdominal lower back pain is associated with a poor performance status, poor mood, and an impaired overall survival. What's the pathophysiology of that pain? Well, nociceptive pain fibers in the pancreas go through the celiac plexus, a mesh of nerves and ganglia which are affixed to the abdominal aorta, go through the dorsal horn of the spinal cord and up to the brain to give the sensation of pain. So how can we treat that pain? Well, there are three modalities: opioids, systemic therapies, and celiac plexus block. Opioids can be extremely effective. However, some patients require such very, very high doses that the side effects can be unacceptable. Chemotherapy, that has a critical role in the treatment of systemic disease, but unfortunately, the duration of response can be limited and side effects, once again, can be troublesome. Celiac plexus block, in which local anesthetic is infiltrated around the celiac nerves, or celiac neurolysis, in which a sclerosing agent is injected. The literature is really rather mixed regarding how effective or not this treatment is. I can say in my clinic, the results have been really rather disappointing. And indeed, a recent randomized study, a small randomized study from Japan that compared analgesics alone to analgesics plus celiac plexus neurolysis actually, unfortunately, failed to demonstrate any efficacy of the procedure. Clearly, something better is needed. But what about radiation? So there have been a number of studies, I think all retrospective, that have used a range of doses and fractionation schemes in order to try and overcome the pain. What unifies all these studies is they all focus their radiation on the tumor itself. And hence, I would like to call this a Hippocratic approach to palliative radiation. A number of years ago, I was sitting brainstorming, or as we say, schmoozing, with my colleague and chair, Sri Simon, and we thought, well, couldn't we do things a bit better? And we said, what about Asclepius? Instead of focusing on the tumor, let's focus on the body's response to that tumor. We thought about a little bit of neuroanatomy and said, what about focusing the radiation on those celiac nerves? And hence was born a proof of principle clinical trial, which we put together with David Hausner, a palliative care doctor. And in that study, you can't see the celiac plexus on imaging, so we use the abdominal aorta as a surrogate marker. We started off giving fractionated treatment, but we found that was inappropriate for this patient population, so we rapidly moved to a single fraction of 25 gray. And here in the diagram in green, you can see the structure. The bulk of my talk is actually going to present the results of this study. The great challenge of this clinical trial is what's called the third part of the duodenum, which unfortunately lies directly in front of the celiac plexus, so we needed to define or create an algorithm of dose painting in order to respect normal tissue constraints. The primary endpoint was change in pain between baseline and 3 weeks as measured on a 10-point scale, and secondary endpoints were the BPI short form. These are the patient characteristics. It was a small study. We accrued a little over 30 patients, of whom just 18 provided useful clinical data. The average patient was in the mid-60s in age with pancreatic cancer who had progressed on one line of systemic chemotherapy. Toxicity was minimal, limited to grade 1-2. This is my most important slide. This is a waterfall plot looking at the change in pain at 3 weeks and 6 weeks. First, we can see almost all the scores are negative. That means almost everybody, the pain increased. Now, you note there's a red line at -2, and that's because in the literature, a drop in pain of 2 points is considered clinically meaningful. And about 75% of patients had a clinically meaningful improvement in pain, and in about a third of patients, the pain almost disappeared. You can look at that in a different way. This is the BPI, has all these types of pain: worst pain, best pain, average pain, my pain now. And in all types of pain, there was a significant improvement, and actually improved more at 6 weeks than at 3 weeks. Looking at pain interference, how much it affects quality of life, you can see all the scores are negative. That's to say, patients said pain's less affecting their working and their sleeping and their mood and their walking, etc. And once again, you can see that 6 weeks is just a touch better than 3 weeks. So, based upon, one more thing regarding dose of analgesics. So, over time, there was a numerical but not significant decrease in the use of analgesics. However, when we looked at the use of breakthrough analgesics, the number of times the patients had to take a short-acting opioid during the day, you can see there's a large decrease. It was on average, it took 4 doses at baseline, 1.5 doses at 3 weeks, and just 1 dose at 6 weeks. So based upon these results, we looked to open a larger clinical trial, and we were fortunate to receive funding from Gateway for Cancer Research, actually based here in Chicago, and some additional funding from the Israeli Cancer Association. The large clinical trial eventually opened sites across North America, Europe, and the Middle East. Now, I can't share with you the results. The study is still accruing, and the Data Safety Monitoring Board doesn't let me have access to the ongoing results. But I would like to share with you a patient testimony from somebody treated at Princess Margaret. The pain was constant and challenging. After Celiac SBRT, it went away completely. There has been no recurrence more than 1 year after. I hope that others may benefit as much as I have. Thank you so much, Dr. Dawson and her team. So where's the study holding? So we have accrued well over 100 patients who have been treated, and we hope to complete accrual by the end of this calendar year. What are next steps? Having completed accrual, we want to analyze outcomes, understand why some patients respond better than others, and also we're developing other indications for non-tumor targeting radiation therapy. I should like to acknowledge the team, in particular, in the audience today, Dr. Maoz Ben-Ayun, who is the physicist who really drove the treatment planning, and all the sub-sites who have recruited patients, including, of course, Dr. Dawson. To conclude, a take-home message. As we develop a new generation of radiation therapy treatments, I think it would be best to remember the input of Asclepius. Thank you very much.
Thank you for that wonderful talk, Dr. Lawrence. Now, I'm wondering what you have in mind for future applications of this. What other sites in the body might we think about? I'm curious, for instance, are there indications like perhaps a breast cancer patient with a tremendously bulky nodal recurrence surrounding the brachial plexus where you might be willing to consider sacrifice of motor function because the pain is so debilitating and otherwise uncontrollable? What are the new horizons for this?
So I think that the key, as in any radiation therapy treatment, is to identify a target. And in pancreatic cancer, we were fortunate there's a clear target that can be identified. Recently, I've established a collaboration with a radiosurgical colleague who works in our pain clinic. And I've discovered that she has a grasp of neuroanatomy that I'm really lacking. And she knows about nerves and things that I don't know if I was ever taught, but if I was taught, I completely forgot about them. Not just me. Okay. Which can be targeted, and I can't give too many details. It's still in the planning stage, but we have got more ideas which we hope to develop into clinical trials in the near future.
We'll look forward to hearing about them.
Well, I wonder if we have a few moments for additional questions, just a few moments. I would be interested in knowing whether or not other kind of applications like the hypophysectomy that's been used sometimes for pain, and in your case that you showed, it was really in a group of patients whose life expectancy is probably fairly poor. So do you see potential roles of that maybe increasing this idea of using this in a very palliative way to improve pain?
So one of the things I've learned from a neurosurgical colleague is that not all nerves are equal. And there are certain parts of the body where the motor nerves run in parallel with the sensory nerves, and the parts of the body where they don't. So I would be concerned about the brachial plexus, because as even I remember that there are plenty of motor nerves there. However, it turns out there are certain parts of the body where you have an isolated sensory nerve, in certain parts of the back, for instance, and there you can treat it. With regard to that, the technique of irradiating the pituitary gland for pain,
yes,
it does exist. I think I'm concerned about the hormonal side effects, but I understand it's being explored in 2 prospective clinical trials, I think one in France and one in Hopkins, and it'll be very interesting to see what happens.
Great. Dr. Evans, any more questions for our distinguished panel?
I think we can probably conclude our session. This has been
Great.
fantastic. Thank you so much.
Thank you all so much.
Thank you. Great talk.
Thank you.